Hello, and thank you so much for joining our webinar today of the advantages of deep learning in clinical cardiac MR practice. This webinar is in partnership with GE Healthcare and the SCMR. And we're excited to highlight the power of deep learning algorithms for reconstruction like AIR Recon DL and speed to improve the overall cardiac experience for you as physicians as well as your patients. For those who aren't available to join us live, this webinar will be available on demand, hosted on the SCMR online learning section of the SCMR website, as well as the GE Cigna Masters website. So before we get started, I'd like to take a few minutes to review some of the housekeeping tips and helpful hints. And one of the most important widgets on your screen is the chat widget. And any point during this webcast, you can enter a question in, and at the end of this talks, we'll be able to have a live Q&A session where a panel of experts will be able to provide those answers. And with that, I'm honored to introduce our keynote speakers. First, we'll have Dr. Alexander Hirsch from Erasmus Medical Center in Rotterdam, Netherlands, and he'll be discussing his recently published peer-reviewed paper on myocardial tissue characterization with deep learning reconstruction. And to follow, we'll have Dr. Shreyas Vasanwala from Stanford University in California, and he'll highlight how deep learning improves the pediatric cardiac experience with rapid and automated approaches to scanning our youngest populations. And at the conclusion of both of our renowned experts' presentations, Dr. Jonathan Weinstaff of Memorial Sloan Kettering Cancer Center and Weill Cornell Medical Center will moderate a panel discussion and live Q&A session that will include questions from you, the audience. And as mentioned, any point during this webcast, you can enter those questions in the comments box. And we'll certainly do our best to get all of those questions answered during this session. And if not, we'll be able to capture those and follow up later. And without further ado, I'd like to introduce Dr. Alexander Hirsch.
Okay, thank you for the opportunity to talk today. My topic is myocardial tissue characterization with deep learning reconstruction. My name is Alexander Hirsch. I'm one of the cardiologists in the Erasmus Medical Center in Rotterdam, the Netherlands. And I would like to talk about a few things. One is the late gadolinium enhancement sequence, the use of different inversion times. Then I'm talking a little bit about parametric mapping and different protocols we can use. And of course, about the new deep learning reconstruction algorithm from GE Healthcare that's called AIR Recon Deep Learning. We did a study with that, and I would like to share the results of that. So if you talk about myocardial tissue characterization, of course, we have the CINE images, which we use a lot in cardiac imaging. Then the T2, T1 turbospin echo. We do a lot of the perfusion. And late gadolinium enhancement. And over the past decade, a lot of studies has been done about parametric mapping of the T1, the T2, and the extracellular volume mapping. First, I'm going to talk about the late gadolinium enhancement. If we look, with the late gadolinium enhancement, we look at relative differences in longitudinal recovery times, the T1. And normally we do the normal myocardium is null, so that looks black. And on the left, you see the late gadolinium enhancement with a subendocardial infarction with a corresponding histology image. And on the right, there's the signal intensity over time after contrast. And when we do the imaging, it's called late gadolinium enhancement because we image normally around 10 to 15 minutes after contrast. And then the blood pool and the infarcted myocardium has a high signal, and the normal myocardium is much lower, and we choose a specific inversion time. So normally, this is from the standard CMR protocols. In the JCMR, we use a 2D segmented inversion recovery sequence. For example, a phase-sensitive inversion recovery or a 3D sequence. These are preferred in appropriate patients with satisfactory breath holding ability. However, a lot of times the cardiac patients have problems with the breath holding, and then you can use a single shot imaging that's preferred as your optional second set or as a backup for patients with irregular heartbeats and or difficulty with breath holding. And in pacemaker ICD patients, it's important to use a wideband late gadolinium enhancement sequence for imaging because you have much better images with less artifacts. So first we do a Cine ER, or it's called TI scout of look locker scan to determine the appropriate inversion time. Normally the myocardium is nulled, is black. That's depicted in image 9. But you can also, for example, use image 5, where the blood is nulled. Sometimes it's useful to set a very long inversion time if there's a suspicion of left ventricle thrombus, where you can depict that much better, where the myocardium is much more gray and the thrombus stays very black. And I would like to highlight this nice paper from Holtackers in the JCMR in 2019. And they looked at the clinical value of dark blood late gadolinium enhancement without an additional magnetization preparation. So it's the same image, and they set the blood nulling, so image 5, but also compared that to the normal myocardial nulling, image 9. So on the left, you see the images where it's quite hard to depict the myocardial scar from the blood pool. And on the right, you see the same, from the same patient, the image where they nulled the blood. And you see a much better delineation between the myocardial scar and the blood. So what they showed that was an improved detection of ischemic scar, especially the subendocardial infarction, and improved image quality. They used the standard SEER sequence for this imaging. So I would like also to show an example. This is a patient with a quite extensive myocardial infarction. On the left, you see a single shot SEER image where we nulled the myocardium. And it's quite hard to see the myocardial infarction compared to the blood pool. On the right is the same late enhancement image with blood nulling. So we only changed the inversion time, and now you see much better the myocardial scar. So what about, we have the T1, the T2 weighted images, we have late gadolinium enhancement, but of course the problem is if it's not a clear quantification. Furthermore, what about diffuse disease, fibrosis, that can may go undetected? So then it's also shown in this figure. On the left, you see the scar, replacement fibrosis or regional inflammation that can be easily detected with these sequences. But the problem is when there is diffuse myocardial involvement, for example, diffuse fibrosis or diffuse edema, also infiltration like amyloid or iron or lipid deposition that can be undetected. So over the past decades, a lot of research has been done on parametric mapping techniques. Here are some examples of tissue mapping. On the left, you see the native T1 map. You see the extracellular volume map. On the upper right panel, the T2 map. You can also do, of course, T2 star and map that. On the right panel below, you see the T1 relaxation curves. So for every tissue or pixel, you can plot the relaxation curves. You can do that pre and post contrast, and then you can also calculate the extracellular volume map. So if we talk about the different pulse sequence schemes that can be used, I only want to highlight the T1 mapping. So different inversion schemes that are used is MOLI, it's shortened MOLI or hybrid MOLI, and a lot of variations has gone around. You can also use a saturation recovery pulse. One of them are Sasha, and GE is offering the SMART T1 map. If you think about the original MOLI, the acquisition scheme was 3-3-3-5. So that means that you have 3 inversion pulses, 3 seconds in between, and then 3-3-5 readouts. So that's a total of 17 heartbeats. So that can be quite long for cardiac patients. The short MOLI is also used a lot, and that's only 9 heartbeats. Personally, I think the original MOLI is too long, so 17 heartbeats is a problem. So what I'm using is a scheme that's called, it's before contrast, that's 5-3-3. So it's 8 readouts with 3 seconds in between and 2 inversion pulses. After contrast, the T1 is much lower. So I think it's important to extra sample the short inversion time, and you can use another scheme. For example, which I'm using is the 4-1-3-1-2, but there are different variants possible, of course. On the picture, you see the 5-3-3 that we used before the contrast. Then it's quite important to go to have motion correction. It can be inline, and also the map generation can be done or on the machine or in different post-processing softwares. So this is how it looks. Then you have all the images. They can be set according to the inversion time, so you can plot the relaxation times and you get the maps. So what about the clinical indications and the utility? It's already quite some years ago that the position paper was published in the JCMR in 2017, but I think it still holds, especially for the native T1 that's decreased in Anderson-Fabry disease, in iron overload, and in fat. It's mildly increased in, for example, diffuse fibrosis or subacute inflammation, and it's strikingly increased, especially in amyloid, but also acute inflammation or acute ischemia. And the extracellular volume can be used for diffuse fibrosis, and of course also in amyloid or in necrosis in scar. And what's stated in the paper is that the clear proven clinical utility is for iron deposition, for amyloid, for the detection of Anderson-Fabry, and for myocarditis. In the meantime, the updated Lake-Louise criteria has also been published, where the T1 and T2 mapping has an important role. There are a lot of other areas, and a lot of research is done on the potential clinical utility in, for example, cardiomyopathy, congenital heart disease, but also acute myocardial infarction, ischemia detection, and other diseases. On the right, you see two different pictures, one of the amyloid case with a clear increased native T1, and on the bottom, it's a Fabry case with a clear decreased T1 time. So for the diagnosis, you can spot now the diagnosis only based on the native T1 maps and on the extracellular volume maps. So these are different diseases. On the left, the normal case, then the myocarditis with an epicardial mid myocardial in the increased ECV in the lateral wall. In the middle, hypertrophic cardiomyopathy case, and then the amyloid and the Fabry case, which I already showed. On the right, on the Fabry, on the extracellular volume, you see an increase in the infralateral wall. That's due to the myocardial fibrosis there. But on the septum, there's a clear decrease of the native T1. But it's not only about diagnosis, you can also use it for prognosis. I only show this, but there are a lot of other studies in a lot of other diseases. But these are two examples of studies, nice studies, looking at the prognostic value of ECV, and on the right also T2 values in amyloid, cardiac amyloidosis. So on the left, it's an ATTR amyloidosis, where you can risk stratify your patient based on the extracellular volume. On the right, it's about AL amyloidosis, and not only ECV, but also the T2 values are important for the prognostic risk stratification. There are a lot of other diseases where you can show the benefit of the parametric mapping. So now I want to talk about the late gadolinium enhancement sequence and the deep learning-based reconstruction algorithm. So it's developed for 2D anatomical sequences, and it's compatible with many standard sequences and options. It's based on the feed-forward deep convolutional neural network, and it's trained with supervised learning using millions of imaging pairs. And what it does, it suppresses the ringing artifacts, it increases the sharpness and the resolution. And what's quite nice about it is you have a tunable noise reduction. So you can set the noise reduction on the number in percentage based from 0 to 100%. So it increases sharpness, there's noise reduction, and there's reduced Gibbs ringing. And how you can use it, you can improve your image quality, but what's also possible, of course, that you reduce scan times to get the same image quality of your images. Here, there are two examples of the standard late enhancement sequence, 2D segmented, and the sequence with the deep learning reconstruction. So this is set at 75% noise reductions. You see clearly the more sharper images and the noise reduction. So these are two examples of short axis late enhancement images. And on the bottom, you see in the infroseptal, in the hinge points, you see myocardial, you see some fibrosis. What we did, we looked at 60 patients with late enhancement images, 30 which had a scar, ischemic heart disease or a non-ischemic heart disease and fibrosis. And first we looked at the sharpness of the image. So what we did, we looked at the image sharpness of the septum, so where the blood going to the myocardium. On the right, you see the image sharpness in the picture with a clear increase using the deep learning reconstruction. It increases directly at 25% noise reduction level, but it further increases with increasing noise reduction levels. We also looked at the image quality. Three investigators scored the images. They scored it as poor, fair, good, very good, or excellent. And on the left, you see the scoring of the no DL reconstruction, and on the right with 70%, 75% noise reduction level. And you see that the image quality was clearly improved. But what about the impact on the quantification of the late enhancement? So, for example, in hypertrophic cardiomyopathy, it's important to look at the amount and the quantity of late enhancement, but also in infarct studies, that's done. There are several techniques to quantify the hyperenhancement. One of the techniques is the full width half maximum, but also that's still used a lot, is the standard deviation method. So what we do is we draw an ROI in the remote myocardium, in the normal, and we look at the mean signal intensity and the standard deviation. And then we set a threshold, like 2 standard deviation, 4 or 5 or 6, and above that, it's called hyperenhancement. And of course, if you use a technique that has noise reduction, then the percentage of late enhancement will increase. So what we found is that if we look at these thresholds, then if we look at the 6 standard deviation, that it can increase more than 100%. So the percentage of late gadolinium enhancement of the left ventricle increases more than 100%. I think the full width half maximum is the best. It's much less reliable on the noise. So there's the best agreement between the manual and the full width half maximum method. So I would like to end with some examples on how we can use this DL reconstruction algorithm. So this is the same patient which I showed before. So on the left, it's a patient with an ischemic cardiomyopathy and an extensive myocardial infarction. And this is a single shot SEER image from the basal to the apex, where you can clearly see the myocardial infarction. We note on the blood, so you have a good delineation between the blood and the myocardial infarction. On the right, the same image, but we used the 75% noise reduction with a much more homogeneous signal from the blood and a nice delineation of the myocardial infarction. This is also a patient with a myocardial infarction. This is again a single shot free reading SEER sequence used. On the left, the standard reconstruction, and on the right, you see there was a reconstruction with 75% noise reduction. You see a clear LED infarction from the anterior wall, the subendocardial infarction over the apex, and there's in the apex, there's a left ventricle thrombus. And you see on the right, clear reduction of the ringing artifacts and also a much more homogeneous signal of the blood. And this is a patient with cardiac sarcoidosis, and he had an ICD implantation. And this is a scan after, so with the ICD. Very nice with the wide band with idiopathic inversion pulse, where you have quite a reduction of the artifacts. You can assess the short axis quite nice. So where you see the lead of the ICD, and in this case, on the left, it's the standard reconstruction again, and on the right, the 75% noise reduction. You see a clear late enhancement of the whole septum, inferior epicardial wall, but also on the right ventricle, which in this case can be very nicely shown even when the ICD was implemented. So it's not only late gadolinium enhancement, you can use it also for other anatomical images. For example, this is a single shot free reading T2 turbospin echo on the left with standard, and in the middle you see with the noise reduction. So we use only the free reading sequence, And you see already with the arrow where the pericardium is quite thickened. It's all in the inferior wall and the lateral wall with the right ventricle. And this is a patient with a constrictive pericarditis. On the right, you see the four-chamber scene, where you can also see the thickened pericardium on the basal to the mid-ventricle level. So you can not only use it in the late gadolinium images, but also on other anatomical images like T1 or T2 images. So I would like to conclude that late gadolinium enhancement, but also parametric mapping, are established imaging techniques in cardiovascular magnetic resonance imaging. However, new developments, including deep learning reconstruction techniques, lead to improved image quality. You can scan, so for example, the reconstruction deep learning can be used for faster acquisition and especially useful for free reading sequences like single-shot late gadolinium enhancement, but also anatomical 2D images. However, be aware of the impact on, for example, the scar size quantification, which I showed in our paper. And I think it's important to notice this, especially if you're going to use it in studies or look at images from different sites. So I think the full width half maximum method is recommended because it's least sensitive to the level of noise and has the best agreement with visual assessment. Okay, thank you very much for your attention.
Thank you, Dr. Hirsch. Very interesting and positive outcomes it found. And now I'd like to turn it over to Dr. Shreyas Vasanawala for his talk on rapid and automated approaches for pediatric cardiac MR.
Well, thank you very much. This is an honor to present on some free breathing, rapid, and automated approaches to pediatric cardiac MRI. There's a strong motivation for efficient protocols in pediatric MRI because patients have a limited ability to cooperate. We're often scanning patients under anesthesia. So we would like to talk here today about some approaches to automation and enhancing the efficiency of these scans. I'm going to cover specifically two different approaches. One is around volumetric imaging, and the other I've labeled conventional, but you see it's conventional in quotes because it's in some ways conventional and in some ways novel. So let's start with the volumetric approach. As you may know, for congenital heart exams, there are several main goals to the exams. This includes defining the segmental anatomy, quantifying flow in various vessels, and also assessing the ventricular function and the size of the ventricles. So the rapid and automated technique that I'm going to talk about today for this, that's a volumetric approach, is a single sequence 4D flow scan. We perform this with contrast enhancement, and it is comprehensive. You'll see that it provides both the function and flow as well as the anatomy in these cases. It's great for technologists because the workflow is much simpler. You don't have to have a detailed understanding of cardiac anatomy and much less having a detailed understanding of abnormal cardiac anatomy. As you can see that after you get a volumetric scan that covers the whole chest, after the fact, you can retroactively reformat images into any plane you want. So for example, here you see in the bottom right, there's the rendering of the whole chest, but then you see in the other panels, the standard views that are in the valve plane, the four-chamber view, and also a two-chamber view. So I'd like to walk you through an example of using this as a single sequence acquisition that is greatly simplified from doing conventional lengthy scans. So here we've acquired this the scan. Again, it's a 4D flow. You can see in the bottom right that the whole chest was covered. However, in order to obtain the standard views that we would like, such as in this example, a short axis, the two-chamber and the four-chamber views, there's an automated detection of the landmarks of the heart that then performs the reformatting into these standard chamber views. So when you open up an exam, you see these types of views. Additionally, there's an automation in terms of segmentation of vessels when determining the flow in these vessels. So here's an example where you can see that there's a valve. This valve, I've clicked on it, and now I'm in the valve plane. And now if I go to a panel, I can scroll to the temporal frame that I'm interested in, click once over that vessel, and now you see the vessel is automatically segmented. and we can see that there's the flow in the vessel that is a little over a liter per minute. So this is just a nice example of automated calculation of flow in any vessel. Again, this is retrospective after the patient has left our imaging suites. Similarly, we can obtain ventricular function from these exams. So I talked first about flow, and you saw how that was calculated. But similarly, on these 40 flow acquisitions, we can segment out the ventricles, both right and left in this case, and determine the cardiac output and ejection fractions. And in this particular case, I'll note that the heart rate was exceptionally high, 150 beats per minute, but we're still getting very good image quality. So here's just that same case, and if you can see in the top left panel, there is a defect between the atria, and so you see there's shunting of flow from left to right with 0.6 liters per minute that was quantified to flow through that shunt. The same case, now you can see, in this case, there's a pulmonic valve, which is abnormally located posterior to the aortic valve. And in this case, we can see that it is a pulmonic valve that is bicuspid. And you can see that fish mouth type of appearance of the bicuspid valve. Here you can see very nicely the pulmonary arteries. So you see the branch PAs, and this gets to sorting out the anatomy. So again, we talked about function, flow, and anatomy as the three primary goals of these exams. So this is just a nice view of the branches of pulmonary arteries. Again, in this same case, you can see that not only was there the shunting at the atrial level, but there's also a patent ductus arteriosus. And so here you see the flow is left to right. And again, it's 0.6 liters per minute. This was also right aortic arch. And now here you see the outlet view very nicely, both along the long axes of the outlets as well as in the plane of the valves for the outlets. And you can see this is a transposition anatomy where the aorta is anterior and the pulmonic valve, which was bicuspid, is posterior. And interestingly, in this case, there was one other anomaly, which was an anomalous left subclavian that was coming from the left pulmonary artery. And so this is a volume rendered view where you can see that very nicely. Here's just another look at that anomalous subclavian, but looking from posterior. So for this case, I've shown that we can calculate flow in any vessels. So I'm showing you just a few different vessels listed to the left, where you can see flow has been quantified in the pulmonic artery across the atrial defect, the patent ductus arteriosus, aorta, pulmonic valve, and also that anomalous left subclavian. But also in addition to that, we have the quantification of the ventricle volume as well as its ejection fraction. And similarly on the right, which was also segmented. So if we look at this case from this single sequence, we've obtained the following information. We know there's a detransposition of the arteries. We know it's a bicuspid pulmonic valve. We saw the patent ductus arteriosus and quantified the flow through it. We also saw that interatrial communication and also quantified the flow through it. Got a great look at the right aortic arch and the anomalous left subclavian, and also quantified the shunt ratio as 4.3. and gave ejection fractions in the ventricular volume. So very nice quantitative exam from a single sequence that just covered the whole chest and did not require dedicated technologist training in cardiac MRI. I want to just point out one other aspect of this, and that is that in all of our phase contrast exams, there are eddy currents that lead to errors in our flow quantification. And this can be corrected. With our 40 flow technique, there is an automated eddy current correction that's performed. So here in this particular case, you see these areas that show in a pink overlay. This is showing regions of non-static tissue or air. And so those are segmented out automatically, and then an eddy current correction is applied. So here you're seeing images before the correction is applied, and you're seeing the velocities shown in the right-left direction, AP and SI. So for instance, if you look at the top right image, you will see that there is a shading across it that is from dark to bright, and that is reflecting the eddy current errors. So now you'll see that these get corrected with this automated correction approach. And so now you have accurate velocity estimation. Again, this all happens behind the scenes. You can touch this up if you want to and hand tune it. But for the most part, this is all automated. There is an upcoming step of automation that's not quite there. This is some work from graduate student Christopher Sandino, who's in the Stanford labs. And this is around velocity unwrapping that is performed in an automated way. So this is not something that's readily available, but just a work in progress. So that was a quick look at a volumetric approach to an automated scan that's quite rapid. Now I'd like to talk about conventional 2D imaging and talk about an automated approach to not only scan prescription, but also some automated processing and a method in which it's free breathing so that you have less taxing on the patient. And from the patient's perspective, happens automatically without a lot of breath holds. So this is some very nice work from Naeem Barami, who's with GE Healthcare. And this is really looking at how to automatically get into the short axis plane, which is the key plane that we're interested in quantifying ventricular volumes and ejection fractions, as well as getting into the four-chamber view. So this starts with the just axial localizer, and then going from an axial localizer, the system automatically, and using a deep learning technique, goes into a pseudo two-chamber view, and then from there into a pseudo four-chamber view, followed by a short axis view. Again, this all happens automatically and greatly accelerates the speed at which these exams can be acquired. And one of the caveats to this, though, is that this whole system was trained on adult patients without congenital heart diseases. So for pediatrics, this is still a work in progress in terms of determining whether this type of automated approach can yield accurate selection of scan planes. So for instance, here you can see a case with a VSD where the system still works reasonably well to obtain a view, but there are even tougher anatomies that can cause greater challenges in automated scan plane prescription. But this prescribing of the scan planes is only one part of the inefficiency of a standard cardiac exam. The other really stems from having to obtain a short axis with multiple breath holds. And these multiple breath holds lead to long exams that are uncomfortable for patients. But more than that, they even lead to inaccurate quantification of ejection fractions. And you see an example of this where you can see the patient held their breath at different positions for the different slices. And so when the segmentation is performed, you can see that there's a shifting between the slices for this multi-slice acquisition. So in order to overcome this, we've been working on a deep learning approach that allows for a greatly accelerated acquisition and at the same time allows for respiratory triggering of the slices of those acquisitions so that you don't have to ask for breath holds. So here's just an example. If you look at this particular case, this was accelerated 12-fold. And what you see is if you just perform a simple zero-field reconstruction, it's highly accelerated and you have a lot of artifacts. Now, at the same time, if you do a fully sampled acquisition, which takes quite a bit of time, you see the high quality images that are obtained. But you can, even with a 12-fold acceleration, use more advanced reconstruction techniques such as compressed sensing or this deep learning approach that I'm presenting today. And you can see that you can recover the images quite nicely. And this is quite adequate for performing assessments of ventricular function and ejection fraction. However, I will point out that the acceleration rate of 12-fold is a bit high for the compressed sensing approach, where you can still see some artifacts in the images. I've showed a blown up version here, and you can see the blockiness in the compressed sensing reconstruction, as well as some structured artifacts there as well. The deep learning acquisition does not have this. So we did a prospective study to look at this. The prior results that I showed you were retrospective, where we undersampled the data after the fact. Here, these are prospective, and so you can see an acceleration factor of 2 is a gold standard using just a parallel imaging reconstruction in the top row. Bottom row is nearly 12-fold accelerated, and you see the good image quality that results here. We did an assessment of the image quality with this type of approach through various means. One is just looking at PSNR. And so you can see that we get a very nice result with deep learning where we get a higher PSNR than compressed sensing. And similarly, using an SSIM as another metric and seeing the good performance again of the deep learning approach. But what really matters to us at the end of the day is our cardiac output and ejection fraction measurements. And so here you can see that we have in this paired examples, compressed sensing reconstruction and deep learning reconstruction. And you see that the tightness of the agreement in terms of the left ventricular ejection fraction versus fully sampled scans is much tighter with the deep learning approach. So here's just another example of this. On the left, you're seeing a panel with the standard Cine acquisition that's done with multiple breath holds. On the right, you see the accelerated one with the deep learning approach. And notice here that you see again from the inconsistencies in the breath holding position, multiple artifacts in the reformatted four-chamber view that are not present in the deep learning approach. And again, this deep learning approach is obtained with free breathing and essentially respiratory triggering, or in this case, just a single breath hold since the scan was so fast. So here you can see some nice work from Evan Zucker, where he looked at the first 30 patients that were scanned with this type of approach, and again, compared with the parallel imaging approach or this accelerated deep learning approach. And notice here the scan time when using just parallel imaging was 10 minutes. Now that 10 minutes does also account for the time that it took to repeatedly obtain the breath holds versus the deep learning respiratory triggered approach, which had a 2-minute scan time. And you'll notice the near equivalent image quality that resulted after a review by two blinded reviewers. So then we expanded the study. It now had 50 patients. And so just some of the demographics are shown here. Most of these studies were done at 1.5 T. 5 of them were done at 3 T. So these were on a GE Artist and an MR750. Vast majority of these were done with patients who were not under anesthesia, just a couple of them under anesthesia. Here's just some representative numbers that you can see and some cases. So an example was a 7-year-old with non-compaction and also a 10-year-old with Duchenne's, both cases where it's very difficult to get good breath holds. And the key point that I'd like to draw your attention to is if you look at that bottom right box, it lists the duration of the scan for each of these. And you'll see it's under 2 minutes for a deep learning approach and over 10 minutes, including the time that it takes to coach the patients with the conventional approach. We did take a look at also the comparison in terms of agreement between conventional approach and the deep learning approach for quantitative metrics of ventricular function. And you can see here that the degree of agreement is quite good. Just one other aspect that I'd like to talk about is, again, the automation. And that is an approach to automated segmentation in this 2D acquisitions for the ventricles. And so here you can see a nice deep learning approach. And with this, you can see that whether there is breath holding artifacts or not, you still get a very nice automated segmentation of the ventricles, both left and right ventricles, that makes the workflow much easier on the interpreting physician. And so here in a brief time, I've showed 2 approaches to a rapid and automated pediatric cardiac MR. The first was a volumetric approach that leveraged 4D flow with automation, and then a conventional approach that had a 2D Cine imaging with deep learning reconstruction that leveraged respiratory triggering to avoid breath holds, and then also some automation for the segmentation at the end in order to get the quantitative metrics out of the exam. And the volumetric approach, which has also its automation in terms of its quantification, and then also the 2D approach that also then has a deep learning reconstruction and then the automated segmentation. So thank you very much for your attention in this presentation.
Great. Thanks, Shreyas, for the great talk and some really great innovations coming out for cardiac MR. At this point, I'd like to turn it over to Dr. Weinstaff to moderate our panel discussion and the questions that we've gotten from the audience. Dr. Weinstaff?
Thanks very much, Heidi, and thanks to Dr. Hirsch as well as Dr. Vasanwala for really fantastic talks in terms of 4D flow assessment, as well as the AIR Recon deep learning approach. Really many questions about this, and certainly a lot of excitement in the future. I'm going to just start off with a question for Dr. Vasanwala from the audience. So obviously the five-fold reduction in scan time for cine imaging is a major advancement and a substantial advancement. Based on your clinical experience, how does this translate into a reduction in overall scan time for patients undergoing cardiac MRI at your center?
Great. No, thank you very much for that question. So there's multiple components to our exams that are done in a multi-sequence approach. So just to step back for a second, some of our exams are done with the single sequence approach that I showed, which involve 4D flow. Then there are others that are multi-sequence exams, and those include doing delayed enhancement, usually 2D cine imaging for functional assessment, and then sometimes some phase contrast. So the component of the cine imaging is roughly, I would say, about half the exam. And there, the deep learning approach speeds that up substantially. So you saw there from exams where it takes, say, 10 minutes to get all the breath holds to do a short axis stack down to about 2 minutes or so. And so that's a substantial reduction. But also this gets applied not just to the short axis, but also to the other chamber views. And so there, each of those also has a little bit of incremental scan time savings. So I would say that, if you put it all together, it's probably somewhere around, 25-30% scan time reduction for the table time.
That's really great. Dr. Hirsch, let me ask you your experience as well. I mean, when we're talking about the AIR Recon DL, deep learning reconstruction for late gadolinium enhancement, what sort of scan reduction times are we talking about for both standard reconstruction as well as 75% noise reconstruction when you're using the technique?
Yes, thank you. Thank you very much for the question. Yeah, you can use it in two different ways, I think. You can optimize, even further increase the quality of your image. So then your scan time from your 2D is the same if you do just one breath hold per slice. But what I really like about it is that in our standard protocol, a standard single shot zero stack is in there. We use the deep learning then to get good quality. And I think that especially for poor breath holders and for arrhythmia patients, that's really beneficial that you even get good quality images from the single shot. So that really increased that. At the moment, I'm still using also my 2D segmented. You can speed up your acquisition, so you can do multiple slices per breath hold and get the same image quality. So that will speed up acquisition also. Yeah.
That's really great. Dr. Vasanwala, let me ask you this. So you've presented really fascinating and important data in terms of the use of four-dimensional flow imaging for congenital, by extension, adult congenital heart disease as well. What other applications are you using the technique for? Is this a standard component of your cardiac MRI protocols? Are you using it in vascular cases? Who gets a four-dimensional flow component of their exam, and how is it helpful to you in terms of your clinical practice?
Great. Yeah, no, thank you very much for that question. So my practice is a pediatric practice. It's out of a children's hospital. So just bear that in mind in terms of the types of applications that I'll present. So we use 4D flow for almost every congenital defect. And it's used for those that don't need delayed enhancement. That's the sole sequence that we're using to interpret these cases. So that's across the range of congenital heart diseases. We do also use 4D flow for some non-cardiac applications. So for instance, we do a lot of solid organ transplant work. So evaluation of renal arteries, renal veins, and grafts. Also for liver transplants, both pre-transplant and post-transplant. for evaluating bare seal flow, and then also post-transplant for looking at the anastomoses and patency of both arteries and veins. And then there are also some other applications that are, I would call, a little bit more niche for us. So for instance, we have some cases where there's mesenteric issues, so the mesenteric vasculature gets evaluated, and other types of things like a fistula evaluation for post-biopsy fistulas in the kidneys, or purposefully created arteriovenous fistulas in the arm for dialysis access. And then also thoracic outlet syndrome is another one where we look for flow disturbances in different positions that the arms and head is put in. So it's across a range of different applications, but the vast majority is congenital heart cases.
That's really great. And I'm going to follow up with you a question regarding your approach towards that in a moment. But first, I'm going to turn back to Dr. Hirsch just with a couple of questions. So first, let me ask you, obviously the AIR Recon DL image quality looks fantastic. You've shown a lot of very, very striking examples in patients with ischemic heart disease or ischemic heart disease related complications, namely myocardial infarction, left ventricular thrombus, and other sorts of complications, which are really striking in terms of clinical applications. Have you used the approach for patients with non-ischemic related late gadolinium enhancement, for example, myocarditis or related sequelae? And what's your experience with that? And then I'm going to ask you one follow-up question, and I'm going to get back to Dr. Vasanwala in a moment.
Yeah, I think that's really important because you don't want to see something else, of course, if you do the DL recon. No, for the study that we did, we had 30 patients with non-ischemic and 30 patients with ischemic, precisely for this reason, to get a mix. We do it a lot. We scan a lot of non-ischemic cardiomyopathy. I never had a doubt that you see the late gadolinium enhancement on your regular image, and if with the deep learning that it changes, the image quality improves. But it of course, and that's what I showed also for the quantification, you have to be careful. You get a reduction in your noise, so be aware, and especially in a non-ischemic area, a lot of sites use the standard deviation method for the quantification. So be aware of the major impact on that. And if you are doing that, not many sites, I think, is that the clinical routine to report the amount of late enhancement of the left ventricle. But if you do that, of course, you have to be very careful because that changes. And if your threshold is, if you use a threshold, for example, if you look at ICD indication in hypertrophic cardiomyopathy, and you're saying the amount of late enhancement is based on that, then you should be careful, of course. Yeah. A lot of studies that are published now, they use a cutoff like 5 or 10%. And that's why I think it's really important to show that's changing. But that's changed, of course, in a lot of other manners also. When you do a sequence and it changes your noise, you get a better SNR. It changes the amount of quantification.
So you preempted my follow-up question, which really gets at the heart of many of these issues. So, this is more of a philosophical question, but an important one. So, what is your experience in terms of the importance of what I'm going to term late gadolinium enhancement quantification at Erasmus compared to visual assessment? And when you're thinking about a patient, for example, with hypertrophic cardiomyopathy, when we place so much emphasis on binary cutoffs, whether it be 5, 10, 15, or 20% for LGE, where do you see us moving towards in terms of use of AIR Recon and other accelerated techniques, which certainly improve image quality? And how are you using that today in terms of guiding your clinicians with respect to ICD implantation and otherwise?
Yeah, thanks. I think that's a really important question, but a very difficult one, because I'm seeing a lot of hypertrophic cardiomyopathy patient in my outpatient clinic. And sometimes there's discussion about the ICD. We look, of course, at the MR and the quantification, but I find it quite hard to report a percentage in my clinical report, because I think the clinicians they don't have the full understanding. They just see a figure. It's really nice to have a binary cutoff, and you say, okay, it's below or above a certain threshold. we like that, but of course that's not reality. And so
Yes.
I tend to be a little bit careful in how I report that. Of course, I report we only report it in clinical practice in hypertrophic cardiomyopathy patients when there is a clear question from the doctor. That's the way we do it at the moment, and we are always discussing it in our team how we should interpret it. And of course, when we compare the previous MR with the other one, that makes a difference also. Yeah,
sure. So,
but
Dr.
it is hard. I'm not sure where we're going, but I find the literature quite hard because most of the times it's single center studies. They present a threshold, and we get a lot of questions. Okay, then we can use it in the clinic at the moment, and we shouldn't do that. So.
Yeah, I completely agree with you. Same experience of both sides of the Atlantic. So, Dr. Vasarwala, let me ask you two questions again on what was a really fascinating talk. So the first is a clinical question, and the second is a technical follow-up. So the first is you really presented very compelling data regarding the use of 4D flow, not only for flow quantification, but also for volumetric quantification. We've also seen beautiful examples in your talk, as well as Dr. Hirsch's talk, regarding accelerated methods, as well as the AIR Recon DL approach for SSFP data acquisition. How much of an offset do you find between one technique versus another with regard to volumetric chamber quantification in your congenital cases? And how do you use that? How do you approach that in terms of clinical reporting? And the second, I'm going to give you a technical question, is following up on that concept. But first, let's start clinically. How do you deal with that, and how do you approach that?
Right. No, that's a great question. So in the past, we've done studies taking a look at comparisons of ventricular volumes and ejection fractions that are across conventional 2D cine methods as well as 4D flow methods. And overall, the agreements are quite good. Of late, we don't wind up doing both types of studies in the same cases, so it's harder for us to now have that dilemma of, well, which numbers do you use, because we have usually one set of data. But I think that one of the things that I like about the 4D flow approach is that the information is all collected simultaneously, right? The phase contrast is collected simultaneously with the ventricular function information. And so for a lot of these patients, you do wind up having fluctuations in flows, in function, even over the course of an exam, right? Heart rate varies. Some of that is just related to the patient's anxiety level, or in my case, with some patients under anesthesia, there's the impact of anesthesia and all the pharmacology that's being administered to them that alters heart rate and blood flows and pulmonary flows. So what I like about the 4D flow approach is that the information tends to be more self-consistent, and because of that, I have a higher degree of confidence in the assessments. But that said, historically, we've done the studies, and I think other groups have looked at this as well, that the agreements are quite good between the two methods. One of the things to really be careful of when doing those types of studies is that often the 2D cine imaging has historically been done as breath holds. And the yes. 4D flow is a free breathing technique. And so even there, the physiology is completely different, right, in the two circumstances.
Right. Absolutely. So this is the technical follow-up question for you. How can you explain, or how do you explain the differences in terms of improved image quality and improved endocardial border delineation for the deep learning SSFP or cine approach compared to compressed sensing?
Mm-hmm. Yeah, great. No, thanks for that question. That's also a very interesting question as well. So if you look at PSNR, I'd like to start by answering this by just saying that's a metric that we should be careful about using. So I showed some data here, but I also showed some other metrics as well, like SSIM. For these types of reconstructions, whether it's compressed sensing or deep learning, these types of metrics, such as SNR, are a little bit almost, I would say, inappropriate, for these types of images, because you can drive the images towards having, very high SNRs. So, for example, like with compressed sensing, a component to this is determining how much regularization there is in the reconstruction. So, if you really push the regularization hard, you will get images that have, high PSNR, right, but don't quite look right.
Right.
So I think the question is really more around like, well, why does the image quality, look better than compressed sensing? And I think this is in part because the compressed sensing reconstruction that we use has this regularization parameter, and you have to set it, right? And so it gets set empirically, and that may be good for a collection of patients, but with this deep learning approach, there was really more of a kind of an individualized assessment there. So I think that you wind up actually getting some improved image quality, in part because you don't have to have one set value of this regularization parameter that's used across a range of your patients, where it's hard to really actually know that you are under the same SNR scenario for, say, small patients with coils very close to the patient, or a very large patient with the coils further away. Or, for example, you have a field of view where a patient is quite small, and maybe that field of view contains less tissue, less air. So effectively, your accelerations are varying, from patient to patient. It's pretty hard to set that regularization parameter correctly, across all cases. So I think that's part of it, and I think part of it is just these data-driven models are quite powerful, and so that's what we're seeing, across a range of exams. I would also say, even for the work that was really nicely presented in the earlier presentation on LGE, it's quite impressive, what these model-based deep learning reconstructions can do.
That's great, Dr. Hirsch. Let me end with a question for you. Are you aware of any data in terms of intra and inter-observer reproducibility or variability of LGE quantification when using the AIR Recon DL approach? Does it yield improved reproducibility, and how is that important in terms of clinical patient prognostication and assessment?
Yeah, so I'm not aware of any published data on that. We looked at ourselves that in that way that we use the software that automatically detects the remote ROI. So if you set, of course, the same ROI as your remote, then the results are exactly the same, and it only depends. So the area is the same. So we didn't look at inter-observer variability. So we didn't check that. So that's one important thing that we should do. The same holds for transmorality. So does the transmorality of the infarction, when we look at viability, is it influenced by this deep learning reconstruction also? So we have to be careful. It's even within single shots and 2D segmented enhancement. Do you see the same? And if you report it for viability, for example. So there is more work that needs to be done on that to look at the inter-observer variability. Yes. Yeah.
So I'm going to end with one question to each of you, which our site is particularly interested in, and that is perfusion imaging using the AIR Recon DL approach. Do either of you have any experience? We're certainly excited about it. What is your experience in terms of preliminary data with that?
Yeah, I like it a lot for the perfusion. Of course, there's a lot of the SNR is lower in the perfusion, and it really enhances the images. So I think it's better. We have done it in our perfusion studies, and I like the AIR Recon. Yes, I certainly do.
We certainly do as well, but the data is going to be coming out for that. Well, I'd like to thank each of you for joining me for this hour-long session. Certainly, it's been a great deal of excitement and great deal of really compelling data in terms of use of four-dimensional flow and AIR Recon DL approaches, certainly which are going to be moving us towards a quicker, faster, more efficient, and more quantitative exam for a whole host of applications. Thanks to the audience as well for joining me, and looking forward to many future discussions in years to come. Thank you.
And we'd like to thank our special guests, Drs. Alexander Hirsch, Shreyas Vasanawala, and Jonathan Weinshaft, and to you for joining us today. And as a reminder, an on-demand version of this webcast will be available to you on the SCMR online learning section at the scmr.org website. And this now concludes our webinar.